Hello everyone, welcome to our lecture for today, Fluorides in Dentistry Part 2. In our previous lecture, Fluorides Dentistry Part 1, we touched a bit on the history of fluorides. We also did look at the mechanism action of fluoride, as well as the physiology and metabolism of fluoride. We also touched on the route of administration of fluoride, both systemic and topical. And notably the water fluoridation we did go through in detail. And for today, it is expected that at the end of this lecture, you should be able to describe the fluoride toxicity and methods of measurement of fluorosis. Fluorides were used extensively in the practice of dentistry to reduce the incidence of dental caries, which we have seen in our first lecture. And excessive use of fluoride can produce a toxicity and even a lethal outcome. That is when it is ingested, inhaled, or absorbed into the body excessively. Now, if you look at this diagram, it will show you the toxicity of fluoride can occur in two ways, either acute toxicity or chronic toxicity. And how does acute toxicity occur? It happens when you have a single large dose ingested or which enters the body, equivalent to about 2.5 to 5 gram. While in chronic toxicity, it is where fluoride is ingested more than the optimal level, but for a longer duration. That means to say that the ingestion is done or carried out slowly. And this will lead to two conditions, dental fluorosis, which is more of our concern, where the ingestion is about in the concentration of 2 to 8 ppm, and a duration of between birth to about 10 years. Whereas in skeletal porosis, it can occur when ingestion is more than 8 ppm for more than 20 years at any age. Now, the effect of fluoride at various concentrations can be seen in this diagram, where if the dose or concentration of fluoride is 1 parts per million, then you will get a dental caries reduction. However, if it is 2 ppm or more, then you can expect to see the mottled enamel. And osteosclerosis can happen when at a concentration of 8 ppm, thyroid changes at 50 ppm, and growth retardation at 100 ppm. When it is more than 125 ppm, we can expect to see kidney changes, and when it is between 2.5 to 5 milligram fluoride, then this is the lethal dose which will lead to death. Now, acute fluoride toxicity can result when the dose of fluoride intake starts from a certain level of fluoride, that is at 32 or 64 milligram per kilogram body weight, which is also known as the certain lethal dose, or in short CLD, and is approximately equivalent to 2.5 to 5 gram of fluoride for children, and between 5 to 10 grams for adults. And for children, the certain lethal dose, or CLD, is between 5 to 10 milligrams per kg. The toxic effects of fluoride is mainly due to 4 different actions. One is burning the tissues. How does it do this? By forming hydrofluoric acid when it comes in contact with moisture, such as the mucous membrane, and it gives a corrosive action. Impeding nerve function by its affinity for calcium, which is needed for nerve function. Third is cellular poisoning through inhibition of enzyme systems. And lastly is impeding cardiac function by causing an electrolyte imbalance, which can lead to hyperkalemia. Okay, let's see the signs and symptoms of fluoride toxicity. Now, when fluoride is ingested, nausea and vomiting can occur. Now, how does this occur, or why does it occur? It is due to the production of hydrofluoric acid in the acid environment of the stomach, which can cause irritation of the stomach wall. Okay, and the local general signs of muscle tetany also can ensue due to the drop in blood calcium. And this can be accompanied by abdominal cramps and pain. Finally, there's a rise in hypocalcemia and hyperkalemia, which can result in either coma, convulsions, or cardiac arrhythmias. So these signs and symptoms can be seen in patients who has fluoride toxicity. In summary, acute toxicity of fluoride will affect the gastrointestinal, causing nausea, vomiting, diarrhea, abdominal pain, and cramps. And its effect on neurological includes paresthesia, paralysis, tetany, depression, and coma. While the cardiovascular system will give you symptoms like weak pulse, hypertension, pallor, shock, cardiac irregularities, and ultimately cardiac failure. And the blood chemistry will show acidosis, hypocalcemia, and hypomagnesemia. The treatment of fluoride toxicity is referred to as a trio of management. Firstly, is by reducing the fluoride absorption. Secondly, is by monitoring the plasma potassium and calcium level. And thirdly, is to increase fluoride excretion. Okay, now according to the dose, let us now see how this toxicity can be managed, right, according to the amount of fluoride ingested. Now, if the dose is less than 5 mg per kg fluoride, the management is by giving milk or to induce vomiting. Now, if it is more than 5 mg per kg fluoride, you can also give milk, induce vomiting. In addition to this is hospitalization and 5% of calcium gluconate. And if it is more than 15 mg per kg of fluoride, induce vomiting, hospitalization, cardiac monitoring, 10% calcium gluconate, monitoring of the potassium and calcium levels, as well as the urine output. Now, chronic toxicity is the ingestion of fluoride over a longer duration of time and more than the optimal level. So, chronic fluoride toxicity is when the fluoride concentration is more than 2 parts per million in drinking water, it will lead to dental fluorosis. And when the concentration is more than 8 parts per million in drinking water, it will cause skeletal porosis. Now, the other chronic toxicity can occur due to occupation, and it is known as the occupational skeletal porosis. This will occur in amongst workers in aluminium industries, or those working in magnesium foundries, fluorspar processing, or in superphosphate fertilizers industries. Okay, over a long duration, it will also lead to fluoride chronic toxicity. Okay, let us now try to understand a little bit about skeletal porosis. It is a non-reversible, incurable disease where it involves the weakening of the skeletal structures caused by high levels of fluorides in water, where the level of water fluoride is over 8 parts per million, as we mentioned earlier. And it is characterized by increase in X-ray density of the trabecular bone, namely the spine and the pelvis, and also increased thickness of the long bone cortices, and this is due to the endostele and peristele opposition. Now, skeletal porosis can be seen here in the diagram as we have described earlier. Okay, it affects the long bone, and it can be seen quite obvious clinically. Okay, in more advanced cases, skeletal porosis involve calcification of ligaments and is known as ankylosing spondylitis. And other effects that may be seen includes gastric complaints, osteosclerosis, and exostosis of the long bone, vertebrae, jaw bones, and also other flat bones. Okay, in the early cases, you may get vague pain in the small joints, knee and joints of the spine, while in later cases, it may involve stiffness of spine and limitation of movement. While in the advanced cases, the patient will suffer kyphosis, which is difficulty in walking, and this is partly due to the stiffness and also partly due to neurological lesions. So skeletal porosis, in other words, can be a very limiting disease. Okay, now dental porosis is chronic fluoride toxicity that, as the term mentioned, will affect the teeth. Okay, so there are a few definitions for dental porosis. For example, Dean defined dental porosis as hypomineralization of tooth enamel or dentin by the long continued ingestion of excessive amounts of fluoride during tooth development. And Murray in 1986 defined dental porosis as a specific disturbance of tooth formation caused by excessive intake of fluoride during formation period of dentition. So in both definitions, we can see that the keywords is ingestion of excessive amounts or excessive intake of fluoride. And the second keyword here is the excessive ingestion of the fluorides actually happen during the tooth formation or tooth development. These are various clinical presentations of dental porosis, from just a white enamel opacities. We can also see sometimes discrete and confluent pitting on the enamel surface, as well as in more severe cases, the corroded brown stain. The possible mechanism of dental porosis. The excessive fluoride will affect the existing mineralizing matrix where there is going to be more rapid deposition and disruption of the crystal growth, and this will interfere with deposition of crystals in the new matrix, and this process is irreversible. Okay, and it also reduces the available ionic calcium, resulting in reduced proteolytic activity. So you can see here that the mechanism actually affects both the mineralizing matrix as well as the proteolytic activity. Okay, so the possible mechanism of dental porosis will include fluorosis occurs when fluoride interacts with mineralizing tissues, and this will cause alterations in mineralization. Okay, in enamel, it will cause subsurface hypomineralization or porosity, and this will extend towards the dentino-enamel junction as severity increases. And this porosity is caused by a delay in the hydrolysis and removal of enamel proteins, particularly aminogenins, as the enamel matures. So you can see here that there is a direct effect of fluoride on the amyloblast. Okay, and interaction of fluoride with proteins or proteinases in the mineralizing matrix. So there are two ways in which fluoride will affect during the tooth development. Okay, early maturation stage of enamel formation. It is a stage where it is particularly sensitive to fluoride exposure. And development of fluorosis is highly dependent on dose, duration, and timing of the fluoride exposure. And risk of enamel fluorosis is lowest when exposure takes place only during the secretory stage, but highest when exposure occurs in both secretory and maturation stages. Primary tooth fluorosis has been largely overlooked. This is because it's often difficult to recognize. However, the distribution within the dentition follows similar pattern as their permanent successors. Okay, the reason being less or rather overlooked in the primary dentition being placenta as selective barrier, where only 70% is being absorbed. Most classification occurs before birth, and duration of enamel maturation is also shorter. And primary dentition has thinner enamel, therefore it has a more whitish appearance. As we have agreed, the distribution of fluorosis in primary dentition actually follows similar pattern as in the permanent dentition. However, assessment of fluorosis is more difficult in the primary dentition and is often overlooked. So the reason being the thinner enamel, as we have mentioned, giving it a more whitish in appearance, and the incremental line of rhizosis, which is often lacking or less pronounced as compared to the permanent teeth. And these two conditions gives it a more subtle appearance in the primary dentition, making it more difficult to recognize. Okay, in the permanent dentition, posterior teeth are more affected, okay, both in the maxilla and mandible. And fluorosis occurs symmetrically within the arch. Okay, and premolar, second molar, maxillary incisor, canine, first molar, and mandibular incisors are mostly affected. We already know that excessive ingestion of fluoride during tooth development will lead to dental fluorosis. The following are factors that may affect the severity of fluorosis. Firstly, fluoride concentration in drinking water, the period of exposure, climatic factors, for example, the temperature, which will affect the quantity of fluoride containing water that we drink, fluoride ingestion through other sources other than water fluoridation, nutritional status, chemical constituent of drinking water other than fluoride, and occupation. Methods of measurement of fluorosis or indices for fluorosis can be divided into two categories. One is fluorosis specific and the other is descriptive in nature. Now let us look at the fluorosis specific type of indices. Firstly is Dane's fluorosis index, the original criteria in 1934. Secondly, Dane's fluorosis index, the modified criteria in 1942. Then we have the community fluorosis index, Tilstrup-Fagerskov or TF index, tooth surface index for fluorosis, often known as TSIF, and lastly the fluorosis risk index. While this descriptive type consists of developmental defect of enamel index, which is DDE, Jackson L-Alusi index, and the Murray-Shaw index. Okay, I will not be going through all the indices, which I believe you have done so in your assignments and seminars. So we will just look at the more popular ones. Okay, so Dane's fluorosis index, was introduced in the early 1930s by Trendy H. Dean. It consists of a 7-point ordinal scale, and each tooth is rated according to the scale. Okay, individual score will depend on the two most severely affected teeth. Dean's Porosis Index is commonly used in prevalence studies. Okay, according to Dean's Porosis Index, which is using the 7th ordinal scale, 0 is for normal, 0.5 is questionable, 1 is very mild, 2 is mild, 3 is moderate, 4 is moderately severe, and 5 is severe. Okay, these are the clinical presentations to define each of the scores that I have mentioned. Okay. All right, now let us look at the Dean's Index, the modified version. This was developed in 1942, and unlike the previous index of the Dean's Index original, it has a 6-point ordinal scale. This index is extensively used today, and in fact, it is recommended by WHO in its basic survey manual. The scoring system here is between 0 to 4. Okay, so 0 is given to a normal, 0.5 is for questionable, 1 is very mild, 2 is mild, 3 is moderate, and 4 is severe. Okay, when it is normal, the tooth will have usual translucent semi-vitriform. It is smooth, glossy, and usually pale or creamy white in color. Then it will be given a score of 0. Questionable, which is 0.5, is when there is slight aberration from translucency to occasional white spots, where it is not justified to score it as normal. Very mild, which is given a score of 1, is when the tooth surface has small opaque paper white areas scattered irregularly over the tooth, but not involving more than 25% of the tooth. And we can also see about 1 to 2 millimeter opacity at the tip of summits of cusps of bicuspids or the second molar. And for us to score mild or 2, what we can see is the white opaque areas, which is more extensive. However, it is less than 50% of the tooth surface. Moderate is given a score of 3, where all the enamel surfaces of teeth are affected, and the surfaces are subjected to attrition where it shows tooth wear. And brown staining is also frequently seen and is a disfiguring feature. Okay, a score of severe of 4 is when all enamel surfaces are affected and there is marked hypoplasia, and the major diagnostic sign is the discrete or confluent pitting and widespread of brown stains, which has a corroded-like appearance. Okay, what is the differential diagnosis when we have characteristics of, looking at area affected, lesion shape, demarcation, color, and teeth affected? Because we need to differentiate between dental fluorosis and enamel opacities. Okay, if the area affected is equivalent to all surfaces, and often is enhanced on or near the tips of cups or incisal edges, then it is most likely to be dental fluorosis. Because enamel opacities is usually centered in the smooth surface of limited extent. Okay, if in case of lesion shape, line shading in pencil sketch which follows incremental lines, or cloudy appearance or snow capping at cusp tips is dental fluorosis. And enamel opacities, the lesion shape is often round or oval. Okay, demarcation for dental fluorosis would be a diffuse distribution of varying intensity, whereas in enamel opacities it is clearly differentiated, where the demarcation is clearly seen or observed. Okay, as for color, dental fluorosis has a paper white frosted appearance and a stain at time of eruption, whereas in enamel opacities it is more creamy yellow to dark reddish orange at the time of eruption. Okay, dental fluorosis always affect homologous teeth, and the teeth that are mostly affected would be the premolars and the second molars. While for enamel opacities, it is mostly incisors and affecting the labial surface of a single tooth. Tooth surface fluorosis index is fluorosis specific index delivered by Horowitz et al. In 1984. Now this index has a scale of 0 to 7. A 0 scale is given when there is no evidence of fluorosis, and definite evidence of fluorosis with white areas less than 1/3 of enamel is given a scale of 1. White area at least 1/3 but less than 2/3 is given a scale of 2. While a scale of 3 is given to at least 2/3 of visible surface. Enamel staining in addition to any of the above is given a scale of 4. Discrete pitting without staining is given a scale of 5, while a scale of 6 is given to discrete pitting with staining. And lastly, 7 is given to confluent or fused pitting with large areas of enamel which may be missing or affected. Okay, now we come to the last part of our lecture, which is the management of acute toxicity. There are three ways, or rather three methods in how we can manage acute toxicity. Number one is by using preventive measures. Number two is clinical treatment. And number three is defluoridation. Okay, as for preventive measures, it is required that we follow strictly recommendations by authorized bodies on how to ensure effective usage of fluoride, which will give us the maximum benefit. ADA has recommended on use of fluoride dentifrices, mouth rinses and supplements in children, and we can also obtain fluoride supplement schedule by AAPD. When fluoride toxicity reaches to a point where it requires hospitalization, the following clinical procedures will have to be done. Number one is setting of cuffed endotracheal tube following gastric lavage. Number two is to maintain a patent airway, to set up an IV line, blood samples hourly to replace plasma fluoride concentrates. replacement of fluid to minimize acidosis and increase urinary excretion, and to conduct ECG monitoring for muscle excitation and tetany. Okay, so what is defluoridation then? It is a downward adjustment of fluoride ion concentration in public drinking water supply so that the level of fluoride is maintained at the normal physiologic limit of 1 ppm to prevent dental caries with minimum possibility of causing dental fluorosis. So it is very important that the concentration of fluoride ion in public drinking water is continuously monitored to ensure that the level of 1 ppm or below is maintained. Okay, defluoridation method is based on ion exchange process or absorption or addition of chemicals to the water during treatment. Okay, these are the techniques of defluoridation. They are either using the ion exchange method, precipitation method, or the membrane separation, which is using reverse osmosis. Okay, the absorption method. This can be achieved with locally available absorbent materials with high efficiency and cost effectiveness, such as bone charcoal, processed bone, tricalcium phosphate, and activated carbon. The process of absorption is dependent on the pH and the presence of sulfate, phosphate, and bicarbonate, which will result in ionic competition. However, using this method, there is a problem of disposal of fluoride-laden sludge. So this could be a disadvantage in using this method. Now, the precipitation method is very well established and most widely used method, particularly at community level. It is moderately efficient and high chemical dose is required. In this method, excessive use of aluminium salts will produce sludge and adverse side effects through aluminium solubility. Okay, while in the ionic exchange method, it can remove fluoride up to 90 to 95%. At the same time, retaining the taste and color of the water. However, it is relatively high cost, and sometimes the treated water has low pH value and high levels of chloride. Membrane processes is an effective technique, and also it does not require chemicals. It works at wide pH range and interference by other ions is negligible, but it has higher cost and requires skilled labor. So it is not suitable for water with high salinity. Okay, the calcium amended hydroxyapatite, it is the most recent defluoridation technique being used. Aqueous calcium is amended to fluoride contaminated water, and successfully it prevents the dissolution of hydroxyapatite during defluoridation and enhances defluoridation capacity of hydroxyapatite. It provides calcium-enriched alkaline drinking water, which is safe drinking water, and also may help in fluorosis reversal. What are the treatment options for dental fluorosis? In many cases, fluorosis is so mild that no treatment is needed. The appearance of teeth affected by moderate to severe fluorosis can be significantly improved by a variety of techniques, and most of them have the objective of masking the stain that is appearing on the tooth surfaces, so as to improve aesthetics, So such techniques may include tooth whitening or bleaching. It will remove the surface stains. However, bleaching may temporarily worsen the appearance of fluorosis. So we have to be very careful about using bleaching. Crowns is another option. Veneers and laminates can be used. These are custom-made shells that cover the front of the teeth to improve the appearance, and it is often used in cases of severe fluorosis. And lastly, we can also do composite restorations. So, in conclusion, the prevention of fluorosis would be to change the source of drinking water to the water containing optimum amount of fluoride. And also, this is done by defluoridation. Okay, so regardless of the type of comprehensive preventive program, community or individually based, the suggested use of fluoride must be balanced between estimation of caries risk and the possible risk for toxic effects of fluoride. Okay, thank you, and I hope, as usual, I would like to encourage you to do further reading, especially using the textbook that is recommended. And also, I'm sure you have done a lot of research when you were doing your assignment and seminar. Okay, see you. Bye-bye.